Well, hi, everyone. I'm Daniel Williams, Senior Editor at MGMA and host of the MGMA Podcast Network. We are back with another Business Solutions podcast, and we are really excited about this partnership with Humana. And today we've got Dr. Jennifer Taylor. She's lead medical director at Humana, and she's going to be talking about peer-to-peer conversations, about perhaps even some work-life balance, about mentoring, about a little bit of everything. So first, let's bring her into the show. Dr. Taylor, welcome to the MGMA podcast.
Thank you very much. It's great to be here.
Yeah, it's great to have you here. So we are going to be talking about a presentation that you gave not too long ago about how to win at peer-to-peer conversations. But first, I would love for you to share with our audience a little bit about your background, about how you got into healthcare in the first place, and what kind of led you to this place with Humana right now.
Okay, so I have wanted to be a doctor for as long as I can remember. It was either a doctor or a policewoman or a social worker. And having chosen family medicine as my specialty, it's all three. There's certainly a lot of social work involved in family medicine and a fair amount of policing too. But I remember when I was little, so I grew up in Youngstown, Ohio. But my mom's family was here, and a little bit of my dad's family were here in Chicago as well. So every year we came to Chicago in the summertime, and my father was obsessed with the Museum of Science and Industry. So every year we had to go, and I was never interested in it. The only thing that ever interested me was their human anatomy exhibit. I think that thing, so it's been in existence. I don't want to date myself, but it's been in existence for a really long time because I looked it up and it's still there. Yeah. But that's the only exhibit that ever interested me. I just loved looking at the bodies, the skeletons, all the different parts, and it just fascinated me. And I knew I wanted to do something that was going to help people. I knew I wasn't really a numbers kind of a girl, which is ironic because that is a nice chunk of my day now, having not chosen so many career paths because I wanted to help people. And here I am as a physician, but now working for Humana. And a lot of my work in helping people does, in fact, involve numbers and business. So the joke is on me.
I wanted to ask you one more thing about that. I love to take in good TV shows, movies, things like that. Did you have a particular TV show or movie growing up that was set in a healthcare setting that you identified with either the lead character or the storyline? Was there anything out there that attracted you to healthcare?
I can't say that I identified with a particular character of any individual show, but you name a medical show and I watched it. And once again, dating myself, Trapper John MD just popped into my mind. Do you remember that show?
Yeah.
Was that like, gosh, I can't even remember. That was probably the 80s.
Yeah,
I think it was late 70s or early 80s.
Right.
But man, I love that show. By the time shows like Grey's Anatomy came along, I think I was already an undergrad or pre-med. So, I kind of knew the difference between reality and what's portrayed on those shows, but I still loved them. I still loved all of them. All of them. Yeah,
Trapper John, you may know this, but it was, I don't know if it was technically a spinoff of MASH, but Trapper John was one of the two lead characters originally. Hawkeye played by Alan Alda, and then there was Trapper John. So he was played by Wayne Rogers. And so, they were in MASH. And then Trapper John, he fast forward, and there he is with his own practice at that point. So that's really good. Yep. Well, I thought I'd just throw that out and ask you about that. And see. I
bet you weren't expecting to hear Trapper John. No.
Of all the ones, I was thinking maybe ER, maybe one of those.
Oh gosh, how could I forget about ER? I love that show. Yeah. That was definitely a favorite.
Yeah, and to date myself even more, going back to the 70s, there was Marcus Welby, MD, but that might have been before your time. But that was one that I watched as a kid. I know
of that, but I didn't actually watch that one. But and you remember Dr. Quinn, Medicine Woman?
Oh, yeah.
I watched that one too.
Did you take any of those skills that Dr. Quinn used out on the prairie there to your own practice?
I can't say that I did, even though I did work in rural Illinois for about 4 years.
Oh, wow.
I don't think I ever had to take any of Dr. Quinn's techniques.
Well, that's wonderful.
Not quite.
Well, it's great getting to just know the person behind all the leadership and the practice that you've developed over the years, to see that you are a human being, because you were talking about how you wanted to serve people, but you find yourself looking at numbers a lot. Talk about that a little bit. What kind of numbers are we talking about? Budgets? Are we talking about analyzing data? Where is your numbers situation shaping up there?
So I'm still making decisions on a day-to-day basis about whether somebody should be inpatient or observation, whether to approve somebody's surgery request, somebody's skilled nursing request, or inpatient rehab. I'm still making those decisions all day, every day. But it's my responsibility to know and be able to help guide the financial implications of the decisions that we make. So that's what I mean about numbers. So we look at trends. What are the leading diagnoses that are coming into the hospital? Obviously, we're in COVID a few years ago, and so that took over everything. But COVID is still around, and so we still keep, our finger on the pulse to see what's going on with COVID. How does that affect the amount of admissions that hospitals are seeing? How does that affect the availability of resources? We're out now of pneumonia and flu season for the most part. But certainly when we start heading into the fall, we see admissions increase because the common cold and COVID and all those respiratory infections, they start kicking in. So those real life things have health implications and have financial implications.
Sure. I have to ask then, when you were in med school, were you prepared? Did you have courses, anything else that prepared you for looking at numbers
Absolutely
and budgets?
Not. Absolutely not. And that actually is one of the reasons why I came up with this talk. I was in med school, 20-some years ago now. And unfortunately, things haven't changed a whole lot in that respect, in terms of the fact that I was not trained at all on how to make the decision whether or not somebody should be inpatient or observation, when a surgery should be approved, not approved, nothing. We got essentially nothing. What I learned was just being on the job. And so doing the job, the hospital case managers would approach and say, "Hey, Dr. Taylor, we think you should change this to observation, or we think you should change this to inpatient." And I was just like, okay. If they told me that's what they thought was best, that's what I did, because I had zero knowledge of this whatsoever. And unfortunately, that is still true for a large number of physicians. It's so much to learn. God, there's just been such an explosion of knowledge in medicine. And with AI, it's just too much to know. you can't squeeze it in. Med school is only 4 years.
Right.
We can't make residency 20 years. So there's just some stuff that you just can't fit it all in. But one of the byproducts of that is physicians coming out of training not knowing how to make these decisions. And so it leads to friction. Mm-hmm. Because you, as a treating physician, you're doing what's best for your patient. You've tried treatment A, B, and C. For whatever reasons, they didn't work. Now you're trying treatment D. And then you get pushback from the insurance company telling you no, that your patient can't have what you deem is medically necessary. And that doesn't go over well.
Right.
that does not go over well. Physicians in general don't like being told no, and physicians particularly don't like being told no by insurance companies and by people who they perceive to not have the same training and knowledge. And so that's why medical directors exist, because physicians should be making these decisions. Clinicians should be making these decisions and not non-medically trained people. So
okay,
that's how I got here.
Yeah. So let's talk about that then. We both have brought up that you have this presentation you've developed on peer-to-peer conversations. You were alluding to it earlier. Tell us what is a peer-to-peer conversation. Let's just define it first, and then let's go in a little bit of depth into your presentation itself.
Okay. So every time a physician wants a treatment, it could be a medication, it could be an admission to the hospital, it could be an elective surgery, anything like that. And also nowadays, it could also be a CT scan or some kind of specialized imaging, more complicated than a simple chest x-ray, something more advanced. Anytime the physician wants to do something like that on behalf of their patient, lots of times there's what's called pre-authorization. So you've got to get permission first. And so there's a board, it's called NCQA for short, National Council, I'm forgetting what all the initials stand for, but it's a governing body, not unlike CMS, which dictates how managed care organizations, insurance companies, how we operate. So we cannot tell a clinician no, you can't have this service for your patient. We can't tell a patient no without giving that treating clinician the opportunity to get on the phone with a peer and talk about why they're requesting it and why it's needed. So that's what a peer-to-peer conversation is, a conversation where we share what's going on with the patient, what's the history, what's the need, and at least half the time, something that was initially denied gets overturned as a result of that conversation. And that's as it should be. Okay. That's the opportunity. That's our first opportunity to get it right.
Yeah. So in your presentation, what are the goals or objectives of it? What do you want to teach or present in that presentation that other doctors and other attendees can get out of that?
So I want the treating docs to know how to get to yes.
Okay.
Because I'm sitting on this side of the phone wanting to say yes. But again, because we aren't trained on how to think through, we aren't trained on what the clinicians on my side of the phone are thinking. So I'm trying to basically give all the treating physicians the answers to the test. I want you to know what are the buzzwords, what are the key factors that you need to say to get to your yes.
Okay. What advice would you give then to physicians to help them best prepare for peer-to-peers?
Take a deep breath. Getting back to that meditation. Take a deep breath before you make that phone call. as much as possible, like center yourself, get somewhere quiet, but probably most importantly, have the medical record open and available to you. Probably 8 times out of 10, the reason why a request gets denied is not because the argument for whatever the service is isn't valid. It's because we don't get enough information. Mm-hmm. Because it's not, even though it's a physician-to-physician decision, we are not the ones who are submitting the information. It's non-clinicians, so not even nurses a lot of times are the ones that are submitting the information. So if you don't give me the right information, then I can't tell you yes. But a lot of times, again, because there's just so many things that encroach upon the treating physician's time. There are so many factors out there that frustrate the day-to-day life of a physician. So sometimes they can get on the phone already irritated. Yeah. Sometimes they get on the phone already ready for a fight. And so if I could get people to, again, take that deep breath and remember that there are some Jennifer Taylors out there who are just sitting there wanting to help you get to your yes. But again, I say that in jest, but that is the Humana approach. Mm-hmm. We look for a reason to approve, not a reason to deny, which is a novel concept because I myself would have never believed that. I never used to believe that. I thought that insurance companies were all that is wrong with medicine. And there's a whole lot of treating docs out there that still believe that. But if you can come to the conversation with an open mind, with the medical record open, and knowing what it is you're requesting for your patient and why, then we can have a good conversation.
Yeah. So at MGMA, as you probably know, a lot of our listeners here, MGMA members, are made up. There are physicians for sure, but we also have a lot of practice administrators, other folks there that serve in those non-clinical roles at a practice. So what would you say to them? What role can they play to help physicians' lives be more, run more smoothly, be easier, a glide path for those physicians? What would you advise our MGMA members who are listening to do?
So this is kind of a dream world for me. But if I could have it,
sure,
it would be, don't have physicians performing tasks that non-physicians and non-clinicians can do. Mm-hmm. Don't take up the physician's time doing tasks that someone else can do. Let us operate mm-hmm. at the top of our license. Let us be physicians. Don't make us be secretaries. Don't make us do all these other things that have nothing to do with treating the patient. We want to talk to and treat the patient in front of us. We don't want to spend all our time looking down at a keyboard or, I guess there's still some folks out there that are handwriting, but we don't want to spend all our time, handwriting in a chart. We want to be engaging with the patient. And so if, like in a perfect world, there would be someone that checks to see what has been requested, what information has been requested, and they would actually give that information, as opposed to submitting, quite literally, Dan, 1,000 pages mm-hmm. of information. And of that 1,000 pages, only 2 pages have the actual relevant information that was asked for. But that's easier said than done.
Right.
And I recognize that.
So we hear a lot about pajama time. I'm sure that is a term that you're very familiar with. So
Yep.
Talk about what can be done. What can be done? I know that you mentioned don't have the physicians do the administrative work, and yet they're going home after seeing patients all day, stuck in that pajama time. Do you work on strategies, solutions, best practices to get physicians out of that pajama time, out of that administrative time, or just offer some advice here as opposed to just saying, hey, don't have them do that, but what is the solution
Right.
then? How do we get around that then?
One of the biggest solutions is scribes.
Okay.
For my colleagues and friends that work in systems where they have a scribe, it has tremendously changed the quality of their life because they are not spending that pajama time documenting. They're not getting in trouble with medical affairs because their charts are past due because they haven't finished their documentation to close them out. So scribes have really, really revolutionized the quality of life of a lot of clinicians. But again, that's a cost that comes at a cost, literally.
Yeah.
But where it's implemented, it can make a huge difference. Again, because it frees the physician to be able to have this face-to-face conversation and pick up all the things and synthesize the things and make the plan with the patient and be able to successfully move on to the next one while someone else takes care of the paperwork.
Yeah. I want you to imagine that you have the opportunity to talk to Jennifer Taylor from, 20 or so years ago, starting out that career. What advice would you give that Dr. Taylor who's just starting out, still kind of enthusiastic about the healthcare world from watching Trapper John and Dr. Quinn, seeing the romantic side of ER.
Right.
There's George Clooney in the hallway. Hey, George.
McDreamy and McSteamy and all those guys.
So what would you tell that Dr. Taylor so, that can set her up for success?
I would say to learn more about the business of medicine.
Mm-hmm.
I attended a family medicine residency where we had a little bit more training about the business of medicine than others, but it still wasn't enough. But again, when you can learn how you get paid, how the hospital gets paid, understand population health, there's just all these factors that go on a high level, whereas you, the physician, again, you're dealing with the patient right in front of you, but there are all these factors that are occurring around you that directly impact your work quality of life and the care that you're actually able to give to your patients. So get on the credentialing committee, get on the quality committee, learn as much, lean into the things that you're uncomfortable with instead of shying away from them. Our natural tendency when we don't know or understand something is to shy away from it because we don't like being uncomfortable. That's just human nature. But this cliche is a cliche for a reason. The only way over is through.
Okay.
You just gotta hunker down and you gotta learn it. There just isn't any other way. If you want to be able to have a seat at the table, because I find myself nowadays, I'm constantly still in meetings, and I've been doing this for, at least 10 years now. But I'm constantly in meetings. I was just in a meeting earlier today where acronyms, there's a language in the business of healthcare as well as medicine itself. I'm constantly hearing acronyms, and I used to just sit there and try to silently figure it out. And now I just come out and ask, hey, what does that mean?
Right.
I just admit, I don't know this. What does this mean? Or does this mean what I think it means? I just ask the question now, because you don't get anywhere by sitting there with your mouth closed, not wanting to appear stupid. You just stay stupid.
Right. No, that's a great point.
You just gotta ask the question. Be curious and lean into the things that you don't know instead of shying away from them.
I love that. Dr. Taylor, thank you so much for joining us on the MGMA Business Solutions podcast.
You are quite welcome.
Yeah.
This has been fun.
It has been. So, everybody, we are going to provide a direct link and direct links to several of the topics, including Trapper John and Dr. Quinn and the peer-to-peer conversations, some Humana solutions, lots of good things out there that Dr. Taylor shared with us today. And so we just want to thank y'all for being listeners to the podcast, for being MGMA members, and for sharing your thoughts and ideas here as well. So until our next episode, I'm Daniel Williams. Thank you again for tuning in.